Okay, that's great. Thank you very much. So I'll be speaking about how to address the inevitable problem of scarring in glaucoma surgery, which plagues us all the way from the original days when trabeculectomy was first invented in the 1960s to how it's been treated with adjunctive antifibrotics in the 80s. And in the 90s, how we looked at different ways of managing it and looked at the risk factors for failure of these operations. Even subsequently, we're looking at newer ways, novel ways of attacking this big perennial problem. And you can see from the diagram on the right there that there's different phases of the healing response that will affect any of our subconjunctival surgeries. And that's what I'm going to basically stick to today. Just to show where some of these things work, you can see that some of the factors affect the TGF-beta pathway, some affect anti-VEGF, that really concerns proliferation, invasion, angiogenesis, and apoptosis. Then you have the monoclonal antibodies affecting the TNF pathway, and then the glucocorticoids and the NSAIDs, as you know, affecting the COX inhibitors. And finally, you've got the antifibrotics like 5-FU and mitomycin working actually on the DNA itself. So we know that preservatives and inflammation affect all parts of the glaucoma pathway, and you can see there's that vicious cycle. And ultimately, it ends up with several problems with our surgery. There's conj scarring, higher infection rate, and also, of course, when you're doing combined surgery, inaccurate biometry. So addressing this ocular surface problem, which is present in many of our patients, leads to quite dramatic changes. You know that the effect of ocular surface disease is mediated via HLA markers, and then this affects the conjunctival epithelial goblet cells, leading to conjunctival epithelial squamous metaplasia, and then that affects the ocular surface by way of a lot of damage. And you can see that damage here when Lumigan's been used, and when you preserve it, change it to preservative-free tafloprost, completely goes away. We did some initial work on how to prepare the conjunctiva for this by giving 2 weeks of FML, and you don't get any pressurizers, but you do stop needlings by quite a significant amount at 6-month time period when you do your trabeculectomies. We also know that PAPs and DEWs cause significant problems to the success of our surgery, not just in the ways of how it can be measured, how our IP can be measured, but if you look at the survival curves, when you've got DEWs, it drops up double the rates it does without. We know for a long time that the more drops that you use, that the more chances that you are going to have trabeculectomy fail. But also, the type of drops that you use are more likely to cause failure in some cases than others. So you can see the worst offender here is bimatoprost. And we also know that the effect of BAK is actually additive. So when you give for longer, it's much, much worse. Now, there's always been this thing about how to address the scarring component by harnessing the immune system. And this is Tony Maltino, and he looked at this cocktail of having colchicine, prednisolone, and NSAIDs. And the problem was that actually it was too complicated and not well accepted by patients. So we're looking at coming up with a similar kind of cocktail from Singapore. And of course, we're going to call it the Singapore Sling. So we have looked at several different things in terms of how to specifically affect the success rates. And we know that in PreserFlow, by doubling the amount of mitomycin, you can get better results. In this case, the number of medications goes down from 0.9 to 0.1, and more patients are medication free when you go for the higher dose. But of course, with this comes several problems. It seems to be mitigated in this position, however, because without many side effects. However, this is always a continuous worry for us. Other things that you can do to optimize the outcomes of these MIBS surgeries is the possible use of phacoemulsification with different mechanisms like flax instead of the usual phaco to reduce the amount of inflammation possibly and lead to better success rates. Controversially, you've got things like addition of subconjunctival triamcinolone and adjuncts like bevacizumab. Now, when you look at PreserFlow, the positioning of it also makes a difference. And this study actually showed that there was a better surgical success rate in 58.2 versus 44.9% of eyes when you use it at non-12 o'clock positions. So you can either put it slightly superior nasal, like about 11, or at 10, or 1, sorry, but not at the 12 o'clock position. Also, there have been several changes in the tube shunt designs as well. So many of you noticed that the newer shunts are actually much more softer materials rather than what they used to be. And that allows better molding along the surface of the globe. And they're also larger designs as well, so that leads to a larger reservoir fluid that can be taking fluid away from the eye. So the change in materials, the size of the plate also tends to lead to better results by changing biomechanical forces. I did a Cochrane review many years ago about the use of mitomycin C in aqueous shunts, and they looked at several different types of shunts, and we found that actually there was not much difference when you used mitomycin or didn't use mitomycin. Now, the thing was that these eyes were generally from very diverse populations and mostly Caucasians, and the diverse indications that they had, some had neovascular glaucoma, some had NTG, showed that actually this was not a very good group to have a look at. And I was doing this because I was wondering about, should we be giving mitomycin C to our Asian patients in Singapore? So when we looked at our own studies, you could find that actually those that had RMED with mitomycin C did much, much better in terms of those that had no drops or were on lesser drops in the longer term at 3 years post-operatively. And this has been found out in other studies as well, the RCTs and other observational studies in the US as well, where they look at Chinese and Asian patients versus Caucasians. And it's probably a useful thing to use in tubes. I don't know how many of you use them in your Middle Eastern patients, but in India, do you use mitomycin for tubes? Yeah. I think it's becoming much more widely accepted now, yeah. And another study that came out of Singapore was one where we looked at early blood failure that can be modified with oral ibuprofen. And those of you not used this already, and I suspect many of you have, because it hasn't really been taken on widely, but it really is useful. You'll see a dramatic change in the morphology of your blebs. There are other mechanical ways of reducing scarring. Some of you may have heard of Ologen, may use it. But it was touted originally as a way of breaking up the scar tissue by having this biodegrading implant that you place underneath the conjunctiva that could possibly get away with mitomycin and all the ancillary problems that gives you. But actually didn't work out so well. It disappeared much quicker than it was supposed to. You can see that at 90 days, only 39% of them were even visible, which was meant to be much, much longer. And actually, in our 1 year results, they actually did need a lot more needlings, 40% needlings in the one with the Ologen group compared to 6% in the just mitomycin group. So it didn't really quite turn out how it was meant to. But what I can definitely tell you is that ibuprofen shows some really good promise in these post-trab and post-tube eyes. We're doing a study on that at the moment. And you can see some of the dramatic changes in appearance when you give ibuprofen just for 1 month with gastroprotection. There are other things that you can do as well in terms of needling of plates. So I don't know how many of you do that in your own countries, but in Singapore, when we do a variety of tubes, including RMEDs, that have got a valve there, then you can actually needle a plate. And it leads to a significant IOP lowering. But of course, it takes time, it's difficult to do on the slit lamp, and you may want to take the patient to OT. So we developed this new way of putting a pre-placed Prolene suture that used like flossing basically, so it breaks scar tissue at that one opportunity. And it's a bit like a releasable suture that you put in, and you just drag the suture out eventually. So there are several different methods that you can use: subconj, mitomycin, steroids, Avastin, and oral ibuprofen, and intense topical steroids to use in these particular eyes, especially at that key point of that hypertensive phase. So in conclusion, encapsulation from fibrosis affects all of our long-term success outcomes from conj surgeries, and the choice of device may help or reduce the impact of these biomechanical forces on the surrounding tissues. We can see that the type of implant also affects. We've seen there's more scarring with Zen than with Presiflow, and part of that is the way it's placed, and also it's part of the SIBS material. Presiflow is extremely inert, so that also helps. But in conclusion, we can look at different ways of helping the scarring process not occur. That's by optimizing the conjunctiva and ocular surface, by giving drug holidays, using preoperative FML, and also intraoperative we can give more MMC if the patient can manage it, and possibility of having anti-VEGF and triamcinolone as well. Post-operatively, we can use longer-term topical steroids, oral adjuncts of ibuprofen, and aqueous suppressants, as you've seen already, plate needlings and adjunct MMC. Thank you very much. Happy to take any questions now if you want to, because I have to head off after this.
chlorouracil around the scarred area in a bleb. Do you think when you're getting a capsule formation around the implant, would an adjunctive MMC injection or a dichlorouracil would work?
Yeah, definitely. And the thing is about doing it preemptively. As soon as you get a worry that it's just not looking as quiet as expected, a bit too inflamed, then best to start giving it. We actually don't give 5FU hardly at all anymore. We only give MMC.
Would you like giving MMC as a subconjunctival injection, or like as pledget soaked in MMC kept over the plate area in the post-operative period anytime?
It is painful to inject, that's the thing, and so some people do prefer the pledgets, and sometimes the eye's very tight and you can't get it to where you want to, so pledgets even in the inferior fornix can work as well. But it is absorbed very nicely through the conjunctiva in the pledget if you want to do it that way. But I think the injection probably works a little bit better.
Okay, can I ask you please about the mitomycin with Ahmed valve? The concentration, timing, and the place of applying mitomycin.
Right. So I really like applying mitomycin in these eyes for a number of reasons. So the first thing is that you give it initially, you do the peritomy, and give the injection straight away. Intratenons, 0.2 milligrams per mil. Okay, that's half the normal dose that we would give, so halve it because it's strong, and you push it into the fornices and let it spread out. Then you flush with 550 milliliters of BSS. And what that also does, it puffs up the tenons and brings it forward, so it's easy to oppose. Especially, I don't know if you have many of these, like when I was in the UK, you have these 80-year-old Caucasian ladies, all their tenons are retracted far back, so they will get those ring of steel blebs. So if you have opportunity to bring the tenons forward, this helps you with it. So it's a mechanical as well as a chemical use.
Is it? Do you encourage to use it as a routine with all cases?
So in our Asian eyes, Chinese eyes, they really scar up like Afro-Caribbean eyes. You probably have experience with those, yeah. I have several fellows at the moment here with me in Singapore who are from the Middle East, Kuwait, UAE, and they've told me that the Middle East eyes do not scar up as much as the Asian eyes do. So we really need that high dose, and intratenon seems to work very well.
Thank you.
Hi there. I've just started using it, so basically I can send you the video of how it's done, but if you imagine it's like if the eyes here, corneas here, and when you look at it, you got those two small loops, you know, like the releasable loops that you put in, and the proline has a position like this, so it's like forms like a circle like this, so that when you pull it, it really breaks through all the scar tissue, and then you just pull it out through one side. So when you get that high pressure, leave it there. It's incredibly inert, because I was worried about the fact that the proline switch itself would cause more scarring, but it's actually really, really inert. Yeah, so oral ibuprofen with gastroprotection, 400 milligrams 3 times a day for 1 month. 1 month only. Oh, sorry, it's meant to be 4 times a day for 1 month, yeah. 4 months is too long, definitely, yeah. Okay. No other questions? Thank you very much.